I'm going to stop that recording.
Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled Fertility Preservation Options for Oncology Patients. We are thrilled to have Dr. Jamie Chin-Hon as our guest who will present. Dr. Jamie Chin-Hon is a clinical pharmacotherapy specialist in adult oncology at NYU Langone Hospital, Long Island, and holds faculty appointment at the NYU Long Island School of Medicine. She received her Doctor of Pharmacy and Masters of Sciences from SUNY University at Buffalo. She completed her PGY1 pharmacy residency at Winthrop University Hospital and her PGY2 oncology pharmacy residency at the National Institutes of Health. She is a past president of the New York City Society of Health System Pharmacists and serves on the NYSCHP Education and Professional Development Committee and the NYSCHP Oncology Symposium Committee. Along with patient care, research, and training student pharmacists, pharmacy residents, student physicians, medical residents, and fellows, she is passionate about quality improvement initiatives to improve efficiency and patient care. Before we get started, I'd like to share some quick points. For those who have technical issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or the chat option. The CE code for this program will be provided at the end of the program. And without further ado, I'll turn it over to Dr. Jamie Chin-Hon.
Thank you so much for the introduction, Dr. Dorson. And thank you everyone for being here today. I'd like to thank the New York State Council for having me present this afternoon. And today I'll be talking about fertility preservation options in oncology patients. So learning objectives will be to provide fertility preservation options and modalities, to review the New York State mandate and coverage for fertility preservation and medications, and to discuss antineoplastic therapies and their degree of fertility risk and fertility preservation. I have nothing to disclose. So looking at the diagnosis of cancer, we see that it has been increasing in the past few decades, but the more important thing is in this presentation is about 9% of new cancer diagnoses occur in patients who are of reproductive age. So we're seeing about 8 million female cancer survivors who have then undergone treatment and have survivorship long-term, and about 5% of those patients are between the ages of 15 to 40. So they have most of their life to live, and the family discussions of family is very much an option for them in their futures. So different types of cancers that can be seen in patients of reproductive age include lymphoma, leukemias, breast cancers, sarcomas, pelvic cancers, and many, many more. And we see that treatments with chemotherapy, especially those with alkylating agents that damage the DNA helix, and also pelvic radiation, can cause patients to be infertile if we don't address it early in their discussions for treatment. There are also therapies such as hormonal receptor adjuvants like the SERMs, selective estrogen receptor modulators, or aromatase inhibitors that will then kind of change the levels of hormones in the patient's body. These can be continued for 5 to 10 years after treatment has been finished. These can affect patients' fertility, as well as surgeries such as ovarian cancer, and patients may need to remove their ovaries or cervix and other parts of their organs that contribute to them having families in the future. Also, bone marrow transplants, these patients will be receiving very myelosuppressive chemotherapy, and it could also affect their ability to have children in the future. We also see a direct relationship with age and ovarian reserve, that the older someone is, then their ovarian reserve decreases with time. So for example, if we look at oocytes or eggs in females, we actually see the most number of eggs in females before they're actually born, so in utero. And there's a steady decline of the number of eggs a female will have with time and how old they are. Then there's a big drastic change around in the 30s, where people will have less egg reserve or less egg release, and quality of egg drops as well. And then there's a very big decline in the late 30s to 40s. And that can be very challenging for people if they're trying to conceive later in life. Similarly, for pregnancy and age, we see that the risk of the opportunities to have healthy pregnancies will decline with age as well, mainly declining in age of 30 and over, or a really large decline 40 and over. And along with this, we see that pregnancy rates have also declined with age, along with miscarriages have increased with age as well. So about 21% of moms had their first pregnancy between ages 30 and 34, and then about 9% of those patients can have a pregnancy 35 years and after. So we see a pretty big decline of the rates of pregnancy in 30 years and after. So the importance is for us to discuss with patients early fertility preservation options, especially if they have malignancy and are undergoing treatment to treat the cancer. So other reasons to preserve fertility in patients with younger age. So this is not specific to cancer patients, but pregnancy rates are much higher in younger women. So if we can save those eggs and make embryos, that would be the best way to save fertility options. We see miscarriages rates lower in younger women because there's less changes in the DNA and high incidence of infertility with patients who are older. There's also the social aspect of having our careers kind of be priority and building our families not as priority until we're a little bit more set in our careers and financially set as well. So there's a balance between family and sometimes career as well. And so what are some of the fertility preservation options? Well, we divide them based on if the patients are of reproductive age, so if they've had their menses for females, or if they have not had their menses, so pediatric oncology patients. If the patients have had gone through puberty, the option of having their eggs grown and stored and frozen is an option. Because so if they have a partner, they can also freeze embryos. So then instead of now freezing one cell of an egg, you then have a multi-cell organism like an embryo that will be saved for future use. And then the option of having ovarian tissue. This is actually experimental as of now, but this can be an option if you save patients' ovarian tissue before they receive treatment. And then there's a discussion about using gonadotropin-releasing hormones or hormonal therapies to then suppress the patient's ability to ovulate and hopefully save their fertility in the future without having undergone procedures and egg retrieval or embryo production. But if patients are pre-pubic age, so they haven't gone through puberty in the female, the only option actually is freezing their ovarian tissue. And this actually is currently under experimental use. It hasn't been approved for use, but this has been a way to remove some of this egg-producing cortex in the ovaries, kind of remove it and save it for later. And then at a later point in time, it can then transplant this ovarian cortex back into the patient's body and be able to use it and kind of like bring it back to life, then have the option to have egg release, ovulation, and become pregnant. So we have a very limited option for patients who are pediatric age receiving chemotherapy or antineoplastic therapies like surgery and radiation. So let's talk about freezing eggs. The first live birth in egg freezing was in 1986. So this was actually 37 years ago. There was about 12 years where vitrification or the preparation of freezing the eggs and thawing them was being experimented. The tricky thing is that an egg itself is like a normal cell where there's a lot of fluid and like cytoplasm. So when we freeze these eggs, they're actually pretty stable, but the thawing process is what can harm the eggs when they are trying to be used when it's time to be created into embryos. So there are several techniques that have been kind of modified throughout the years, and there's much better techniques nowadays that have much higher chances of survival of these frozen eggs. So looking at what an IVF cycle looks like, it's always based on the woman's menses cycle. So the first day will be the first day of the period, the first day of bleeding, And then the patients are then monitored with blood tests to measure their hormone levels. Then they undergo about 9 to 14 days of injections with gonadotropins to help stimulate egg production and growth. Meanwhile, the patients are coming in every day to monitor the growth of those follicles or eggs that are being stimulated by the injections. They also come in for blood draws on a daily basis to make sure that the levels are increasing appropriately, but not dangerously increasing that would put the patient at harm. And then about day 14, they are then instructed to give themselves a trigger shot, which is usually leucoline or an agent to help stimulate ovulation. And then the patients are then scheduled to come in for the egg retrieval, where the patients are being placed under anesthesia and they are then extracted. The eggs are being extracted under a very quick procedure and saved for later use and frozen. And then depending on when they receive the treatment, they could save these eggs for years in the future. Also depending on when the patients are ready to use their eggs or embryos, they can then transfer these embryos or eggs at a later time. So this whole process takes about 2 to 4 weeks, depending on the steps required. And there are several, like coordination steps needed in this process to have the patient have the time and resources to receive all the medications, to get monitoring, and be able to somewhat delay their treatment in order to save some of their eggs and embryos for the future. So looking at what the egg retrieval looks like, you have this probe that goes into the vagina, and then under imaging, a needle is then inserted into the ovary, and follicles are then retrieved. So the next slide actually shows a video. So those black dots or black circles are the actual follicles, that there's a needle that goes into them and it draws out the fluid. So follicles are, they're kind of like cells that grow on the outside of the eggs. And when you drain the fluid in the follicles, you're then collecting the eggs within them as well. So then an embryologist will then use samples and be able to remove the follicles so that they only just have the eggs, and they can freeze those. But the follicles are like a protective layer around the eggs to kind of ensure the growth and protection. And so in regular ovulation, when you don't have an IVF cycle or egg stimulation cycle, the body actually only chooses one egg to be stimulated and grow, and that egg is then ovulated. Whereas in an IVF cycle, the goal is to grow all the eggs and not let the body destroy the rest of them. We don't want to select just one to ovulate. We're then growing all the eggs, so we have the highest chance of retrieving all of them and then using them all in the future. And then we collect them all, and they also look to see how many of them are mature, how many of them they can save, and the act of saving them in the future is quite a few steps with the embryologist. So what happens after we retrieve the egg and or embryo? The patients are then monitored. They could have some symptomatic pain, such as fluid in the abdomen due to the fluid shift from third spacing. So with a lot of these hormonal therapies, there's a lot of fluid accumulation from the hormone stimulation. Patients can then have enlarged ovaries. So those are the ovaries that are stimulating the egg from being released. And also from the procedure itself. The patients can also develop cysts in the ovaries too. And they may have a positive HCG, but it does not mean that they're pregnant. It just is a side effect of this procedure and the medications. So of course, the women are then followed up for monitoring to make sure that these symptoms aren't too bothersome, that they're advised to kind of rest and also try to limit their fluid intake so they don't get too edematous and have ascites or too much of a fluid shift. They may or may not receive depo-lupron because that can help with the symptoms, but depending on the patient, they may or may not need that. And the younger the patient, we usually see higher risk of ovarian hyperstimulation syndrome. So that's also something we watch out for and monitor the patient to make sure that their ovaries don't become too swollen and potentially, like, in a sense, rupture. Then this whole process will be discussion with the oncologist and the reproductive endocrinologist to see if they have the time and resources to delay treatment in order to have this fertility preservation option available. And if they do not, then they may look at other options. But looking at the benefits and risks of, is this fertility preservation option available, or is treatment more urgent, or is the patient even eligible for fertility preservation options such as IVF? So looking at what IVF also is containing, classic IVF is when an egg is placed with multiple sperm in an environment, and the sperm naturally will then inseminate the egg and fertilize. Whereas there's another procedure called ICSI, and this one injects one sperm into each egg. So it's more selective. Usually there's another procedure before this called Zymot, where the sperm have to swim through a very viscous gel, and then this sperm that pass the gel are considered the most fit because they have been able to physically pass the gel and not get stuck. Then they choose those sperm to then be injected directly into the egg. So there is no question if there's fertilization. They just make sure they fertilize all the eggs. And so in normal conception, we have a female who ovulates an egg during their menses cycle. Then the egg travels through the fallopian tube and is then exposed to sperm, where the sperm is then fertilizing the egg. Then that fertilized egg becomes an embryo or fetus, or blastocyte in a sense. Blastocyte meaning it's an early cell that is starting to replicate, in every few minutes it then doubles in the number of cells until it gets to a larger cell. And the blastocyte then will implant into the uterus, and that's where the baby becomes larger and grows and continues to grow. So in IVF, the fertilization process occurs outside the body, and then the embryo is then saved and implanted into the uterus and allowed to grow over time, while the patient's monitored with supportive medications and monitoring. So now we'll talk about genetic number of chromosomes. So embryonic aneuploidy means that you have a normal number of chromosomes, so 23 chromosomes from the sperm and 23 from the mom or the egg. And we see that the risk of having abnormal number of chromosomes will increase with age. So for patients who are 30 years old, we have 32% of patients with abnormal number of chromosomes. So aneuploidy is abnormal number of chromosomes. And as we get older, there's higher chances of having abnormal number of chromosomes from the egg itself. And this is also similar to the sperm. With age, we see that the number of mutations in sperm and egg will increase with time. And this could lead to miscarriages as well. So there's something also called pre-implantation genetic testing. So once we get someone to have a embryo, there is an option to have a part of the embryo then tested to see if there are abnormal number of chromosomes, as well as other genetic mutations such as like Down syndrome. And so this is typically something that the patients have to consent to, both the mother and father. And it helps to provide better information about if that embryo is more stable. So if that's the case, patients will have to go through something called a frozen transfer, where they create the embryos first, and they can biopsy the embryos and save the embryos for later. Then after the results of these testing come back, the parents can then select when they want to transfer the embryo. But depending on, I guess, the decision of the parents, they may have information that some of the embryos are not genetically normal and some of them are, and they have to make a decision if they want to keep the ones that are not genetically normal, or if they feel comfortable transferring. But there's a whole consultation service that will discuss the likelihood of abnormal embryos making it to a live birth, or if there's a risk of physical or genetic or cognitive impairment for the outcome of the baby. And then the alternative is that if patients want to do a fresh transfer, they create the embryos right away, and then they can transfer that embryo directly into the uterus to grow the baby without having genetic testing offered. So there are several types of options to see if the parents would like to know if the genetic testing results or continue without knowing genetic testing results. So if we talk about hereditary cancers and there's some mutations, the big one is BRCA1 and BRCA2. This is a common tumor suppressor gene that sees mutation in the P53 and TP53 genes. And these mutations are prevalent in breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. So if a patient has these mutations, they may need to have the decision as well to undergo further testing and see the risk of them passing on these gene mutations to their offspring. So the pre-implantation testing, especially if they're making the embryos and then testing them to then see if they have the mutations, is an option, especially for patients with a history of these types of cancers. And that can help to know more about the embryos for the future if they want to use them to build a family. Though a challenge for this is it takes about 2 to 4 months to develop assays specific to the patient's genetic mutation, and that can take some time. But if patients are undergoing these fertility preservation options before they receive treatments, usually their cycles of chemotherapy and surgery, if they need it, may take about 4 to 6 months. So this may be a good option to do before undergoing any treatments for the cancers. And so what are some other factors that are considered in cryopreservation? So age is number one. The younger the patient is, the higher the chance of the egg retrieval and the embryo creating healthy embryos, which lead to a higher birth rate. And we also have to consider, is there an option to delay cancer treatment? So if we think about some of these more urgent treatments that we need, especially in acute leukemias, we may not have enough time. We may not be able to wait about a month to have an IVF cycle or egg stimulation cycle in order to treat the patient. So, but whereas another type of cancer that may not need to be treated right away, such as a type of solid tumor, they may have the ability to pause treatment options for their cancer, undergo a cycle of ovarian or egg retrieval and collection, and then go on with plans for potential surgery and or chemotherapy or radiation. And then also the level of hormone sensitivity to malignancies. So particularly in breast cancer and ovarian cancers, if the breast cancer and ovarian cancers are dependent upon estrogen and progesterone, then that may be a challenge, because in those patients, we are giving them gonadotropin releasing hormone or gonadotropin therapies to help stimulate follicle growth, and that can be harmful in patients with an estrogen producing cancer such as breast cancer. So that's another consideration that we have to take look at and review and see if, like, what are the best options in fertility preservation for these types of patients with these types of cancer. So another option is that ovarian tissue cryopreservation and transplantation. This was the experimental option, especially for the patients who are pre-pubic age. So we see that this has been studied in animals for more than 60 years, but the first human transplant for this ovarian cortex was done in 1999 by Dr. Okte. And from this, in 2004, there was a first human live birth from someone who had a frozen embryo tissue transfer. So that was pretty incredible to have that option in patients who are pre-pubic, and potentially an option for those who are post-pubic who cannot tolerate the therapies and the timing to undergo the egg retrieval and egg growth. But this has been something kind of novel in a sense, because it's pretty much removing the cortex of the ovaries, saving it for later, and then being able to transplant later when the patients are healthy and well and able to plan for a family. And so With this, once the ovarian cortex tissue is removed, the patient actually goes into menopause, so they're no longer able to have menses or their ovaries are not being stimulated to ovulate. It's still considered experimental and an option for patients who are prepubic. There's also, the procedure itself requires a slow freeze of this ovarian cortex, and then it's really important to then reperfuse the organ with blood in an area that's very vascularized. And ironically, the patients, when they are retransplanted the ovarian cortex, it's not back into the ovaries. It's actually on another area, like their forearm, their abdominal subcutaneous area, anterior abdominal wall, somewhere where there's muscle and some fat, where they can reperfuse blood flow to the area. And it's a pretty interesting procedure. So for males, it's a little bit different because the main thing is preserving sperm. So the big thing is freezing sperm in patients who are post-pubic, so have gone through puberty. They can freeze their sperm and save it. They can do multiple sperm collections. And then in the future with their partner, they can then thaw the sperm and have intrauterine insemination, IUI, or they can undergo IVF and have the egg then be fertilized outside the body. So for what's a process if the patients are prepubic, so male patients who have not gone through puberty, especially those pediatric oncology patients, in this case, it requires this procedure. So patients could undergo fertility preservation by going under anesthesia, and they will then have to extract the sperm and save that through a procedure. Then that sperm can only be used through IVF or the ICSI procedure. So looking at these different types of options, let's compare them across the board. So these are mainly for females because they have to undergo more of a complicated process. But if we are saving embryos, so making embryos, we would need sperm at the time of the egg retrieval, versus if we're saving eggs, sperm is not required because we can then save the eggs by themselves. And then if we're saving the ovarian tissue, the cortex, we do not need eggs as well, just saving a piece of the organ for the future use. Legally, they're making embryos is a shared ownership. So of the person owning the sperm and of the person owning the egg, they have to be in agreement to then decide when to use that embryo. And if one doesn't agree, then the embryo cannot be used. Whereas egg freezing and ovarian tissue freezing is only of the woman's possession. So there's no need for consent or shared ownership. Delays in chemotherapy for egg freezing and embryo freezing, we have to delay chemotherapy because we are having to need the patient for about a month to stimulate the eggs, follicles, and then retrieve them. Whereas ovarian tissue could be done much quicker and save a lot of time. For those who have not gone through puberty, embryo and egg freezing is not an option because they're not able to, patients cannot able to ovulate their eggs, whereas ovarian tissue is the only option. And then requires hormonal stimulations with those gonadotropins. Similarly, for the egg retrieval and the ovarian, for the egg retrieval and the creating embryos, they require the hormonal stimulation, the gonadotropins, whereas ovarian tissue does not. And the only one experimental is right now the ovarian tissue. But we see live birth report with all three methods. So that's a huge benefit. And then resuming endocrine function. So for patients who have the embryo and egg freezing, they're like halting endocrine function. Whereas ovarian tissue, well, actually, they actually go through menopause. So I think I switched this in the graph. But there's a temporary halt in ovarian function for these three, but the ovarian tissue is actually a halt somewhat more permanently. Okay, so what do fertility specialists need to know before starting fertility preservation cycle? So these are our reproductive endocrinologists. We need to know the female's age, their desire, if they want to have children or not, If they do not, then we may not need to go through all these steps. If they have a partner, if they're single or a spouse, if the partner is male or female, the presence of their cancer, if it's on the ovaries or peritoneum, because that could be a risk of recurrence if we then give them hormonal therapies. Also, the health of the patient to see how they can tolerate this therapy, as well as what's their diagnosis of cancer and what the health is of them with their cancer. Also, what's the risk of anesthesia causing them harm? Do they have protected airways? Do they have sleep apnea? What's their BMI? These can be risks if we, these can be risks of undergoing anesthesia. So to make sure the patient's safe to undergo anesthesia. And then the accessibility to ovaries. So yeah, how is there anything obstructing the ovaries in terms of malignancy or physicality? Also, do they have time to go through an egg preservation cycle, that 1 month? Do we have enough time to go through that? Also, type of cancer, if it's sensitive to hormones such as a breast cancer and ovarian cancer, and then what types of hereditary cancers or mutations that the patient may carry. So what are some counseling points when we have patients who are newly diagnosed with cancer and are considering fertility preservation? We want to make sure that we discuss with patients that who are of legal age. If they're not, if they're younger, we need to have their legal guardian or parents be involved in the discussions as well to consent them. Also, the access of care. So access of care meaning, are they available to come to the appointments? Do they have any physical restrictions, time restrictions, cost restrictions as well? And they may also be very overwhelmed to deal with their new diagnosis of cancer, as well as facilitate many consultations with other physicians and providers, and also the resources. Do they have to go to work? Do they have other obligations like children that they have responsibility for? So many things that can be challenges in patients who may want to pursue fertility preservation and kind of their day-to-day workflow and requirements and responsibilities. But the goal is to have hope and give patients an opportunity to think about what's life after cancer. So we consult the reproductive endocrinologist and infertility specialists for those who even wanted to have a discussion, because it's very important for them to understand all the options out there and what's available to them in their particular circumstances. So they may have questions about egg freezing, sperm freezing, creating embryos. They want to have also want to assess like how many children they want, when do they want to have them, also assess their age and see the risks and benefits of a patient who's maybe in their 20s or 30s or 40s, and then talking about the side effects of the therapies that we're giving them during their cycle as well as after, and then checking on different levels to see if they're even able to have the option of stimulating their eggs and ovaries to make eggs and embryos in the future. So are they even candidates or fit for these possible fertility preservation options? And so if they're not, other options to have a family could be having a donor egg or donor sperm, also donor embryos, so having someone else's embryos. If they do have the option to save their own eggs or embryos and they cannot carry, there's a potential for gestational surrogate, so someone else carrying their child. Also the option for adoption or foster care, and potentially even not having children at all. But these are other options if they may have challenges in conceiving or carrying their own child. And these are discussions to have with the patients as well, and their family members and spouses. So now we're going to go into some of the mandates for insurance coverage. So the New York State mandate actually has a law from 2019, and several of my colleagues in the fertility and infertility reproductive endocrinologists, they've been part of a lot of legislation and grassroots advocacy to get patients with cancer the opportunity to have coverage, insurance coverage, and also financial coverage. and have the ability to save their fertility for the future, because this is very important, it's very prevalent. So we see that the New York's insurance law requires individuals, small and large group insurance policies to provide insurance contract, hospital, surgical, and medical insurance and care involving fertility preservation options, and funding for these patients who are in these very, very stressful circumstances. So there are two different types of coverage. There's the New York State coverage. So in this case, we have individual, small, or large group companies over 100 employees provide the opportunity for these benefits, these fertility benefits. There's also some non-funded companies. Usually they need more employees, about 1,000 employees or more. So larger corporations. And then there are some self-funded groups that are not required by law, but for example, there's one called Progeny. This is something that is a benefit or insurance benefit that provides coverage, and it could be offered by the company itself. Like whoever's under the insurance can have this elective fertility benefit outside of the state, and they can offer quite a bit of funding and insurance coverage. So these are results of a lot of legislation we just saw, which is pretty phenomenal, and it's relatively recent, which is great to see. So with the New York State mandate, we see that center fertility preservation services are required to be covered. So this includes the collection and freezing of the egg and sperm, preservation of these genetic materials, storing these materials over a period of time. There's also a lot of costs to the medications required, such as those gonadotropins and other therapies, injectables. So those can be also covered with these insurance options. And then the cost of deductibles, co-payments, co-insurance, these all come along with the procedures that are involved, as well as the appointments and other contributing costs of having these fertility preservation options available. Along with insurance, there are some pharmaceutical companies who then provide some patient assistance programs similar to some of the other medications we've seen, especially in anti-cancer therapies. There are several patient assistance programs that provide medications at no cost or reduced cost. So some pharmaceutical companies offer some coverage and free medication to patients. And this often requires the oncologist to fill out a form to verify the cancer diagnosis and facilitate prescriptions being sent and monitoring. So the next part of the lecture is to review some of the therapies that can have impact on infertility. So we see that in pediatric cancer patient survivors, there's a risk of endocrine dysfunction, and this can be seen in patients in different organs. So about 75% of patients who are pediatric cancer survivors have changes to their quality of life after they receive treatment. And for some of the examples, we have thyroid disease. They can have early onset puberty. So that could be before the females turn 8 years old and before males turn 9 years old. You can see delay or arrest in puberty. Could be changes in their hypogonadism. You could see changes in their ovarian function or reserve. You could see metabolic syndrome, impaired bone health, or in general infertility. And this could be directly related to their anti-cancer therapy, such as surgery, chemotherapy, radiation. So mechanisms of chemotherapy-induced infertility are mainly affecting the sperm in males and also the egg production or the egg quality or ovarian reserve in females. And this could be seen from the treatment itself. So we have Badashi et al. And colleagues. They looked at chemotherapy risks to infertility in females, where the most prevalent class of medications, alkaline agents that damage the DNA synthesis or damage DNA, have the highest risk of infertility. So these are therapies such as cyclophosphamide, ifosfamide, chlorothiamine, chloramicell, busulfan, melphalan, used in a wide range of cancer, so leukemias, solid tumors, sarcomas. We see that alkaline agents have the highest risk of causing infertility in patients. And very similar to alkaline agents, platinum agents have a very similar mechanism. These also bind and damage DNA. And cisplatin and carboplatin are signature ones. Oxaliplatin is another one as well. But alkaline agents, platinum agents have the highest risk of infertility, whereas other classes of medication, antimetabolites, alkaloids, anthracycline, antibiotics, we see actually much lower risk. But unfortunately, a lot of these therapies that we give them are in combination regimens. So having an alkaline agent or platinum agent within the treatment regimen is relatively common. So you can see some effects. And then looking, and Klipstein et al. Looked at risk of infertility in males and females, and similar to the Dashi et al., it's alkaline agents and heavy metals. So very similar in class. Then in males, we see lower risk with lower alkaline agents and maybe dose dependent. But the other classes like antimetabolites, anthracyclines, alkaloids, they have much lower risk of infertility. So goals of treatment is always cure if we can. We see that we want to maintain dose intensity of chemotherapy agents and also dosing frequency and keeping patients on their treatment schedule in order to ensure that we're treating the cancer for the full intent. And so as much as possible, we want to maintain the highest dose and support patients through their side effects, but also seeing if we need to, I guess, avoid dose reductions if possible, because then it compromises treatment. But of course, then making sure the patient themselves is tolerating it okay, because if they are not, then we may need to dose reduce or increase the time between treatment cycles. And we want to also look at the maximum cumulative doses of certain agents. For example, like bleomycin and the toxicity of lung. There's also anthracyclines and the cardiotoxicity risk as well. So next we're going to go through some markers of fertility and some of the hormones that we would be measuring. There's the anti-Mullerian hormone, or AMH. It's made in the ovaries and regulates follicle growth, and it also helps to measure ovarian reserve. So when patients have low AMH, they usually don't have their normal menses cycle. And if they're very low for a long period of time, it may mean that they're going into like a menopause. The follicular stimulating hormone, or FSH, is made in the pituitary gland and helps to regulate the menstrual cycle and stimulate egg growth. So we see the FSH peak when the patients are going into ovulation, and that's usually when patients are testing their ovulation. The FSH peak is a signal to show that they're able to plan for conception. And then the luteinizing hormone, LH, is made by the pituitary gland. This is important for the egg maturation and also is a marker of ovulation as a trigger. Then we have estrogen, progesterone, two hormones that are made in ovaries and also the peripheries. And these levels may vary throughout the menstrual cycle, but this is used to measure patients during an IVF cycle to prepare for the patients during their egg retrieval and also their ability to have the implantation for the embryo. So next we see that different levels of risk of infertility is based on age as well. And so, for example, many of these regimens are combination therapies that contain alkaline agents and or platinum agents. So those are the ones that are very high risk for causing infertility. This risk is also a measure of age. So the patients are, well, the two markers are usually 30 years old, 35 and 40. If the patients are over 40 years old, there's a higher chance of having infertility affecting the hormone levels like the AMH and the risk of menopause when patients are receiving these treatments. But when they are receiving them earlier and at a younger age, we see less of an effect on their AMH level and their ovarian reserve. So we're seeing that if patients are then treated in their younger ages of reproductive age, then maybe there's still a chance of us seeing the fertility for the future and then being able to do an egg retrieval or embryo retrieval, save them for later, get the treatment for chemotherapy, radiation, surgery, and then they have a better chance of saving the fertility for the future. Whereas if they're over 40, it might be more challenging because their ovarian reserve is already low. and undergoing treatment will also affect their ability to conceive or carry a child. We'll go into the next slide, but other therapies other than chemotherapies that are cytotoxic are targeted therapies, so small molecule inhibitors such as the oral tyrosine kinase inhibitors, along with biologics, those monoclonal antibodies, and then those immunotherapies such as checkpoint inhibitors. We'll talk about those in the next few slides as well. So targeted therapies, we have, for example, VEGF inhibitors such as bevacizumab. This is just a very specific, particular biologic, but VEGF is vascular endothelial growth factor. It's a growth factor that's highly expressed in ovarian tissue, and it's normal for ovarian and follicular development. So it's actually dependent on if the patient is pre-pubic or post-pubic. If the patient has not gone through puberty yet, and they're exposed to bevacizumab, then they actually have a higher risk of changing their ovarian development and follicular development. And this may challenge them to have the ability to have fertility preservation later in life if they have not stabilized that cortex, that ovarian cortex. But if patients are post-pubic, like they have gone through puberty and then they receive the bevacizumab or VEGF inhibitor, we actually may see that there's almost no change to their fertility. So in those circumstances, this particular biologic has different effects on the woman fertility risk based on if they have gone through puberty or have not gone through puberty. Another example is trastuzumab. This is the HER2 inhibitor, along with lapatinib is an oral tyrosine kinase inhibitor of HER2. This actually has no effect on AMH level and may have a protective effect on ovarian function. So this monoclonal antibody or oral tyrosine kinase inhibitor may not have any effect on fertility at all in patients who are pre or post-pubic. So just to show you very different options or like exposures, that it's really not the therapy we're giving that's a broad blanket effect. It's really the target and how that target has an effect on ovarian reserve and or effect on different hormone levels. And then looking at some of these oral tyrosine kinase inhibitors, the big one that somewhat triggers like a lot of discussion are these kinase inhibitors that inhibit BCR-ABL. So BCR-ABL is a gene mutation that occurs in patients who have a Philadelphia chromosome abnormality. This is seen normally in acute lymphocytic leukemia or chronic myelocytic leukemia, CML or ALL. And there seems to be a disruption in the egg and also follicle maturation, also in ovarian cell apoptosis and ovarian release of progesterone. And this particular class of medications have seen to cause infertility and or challenges if the patients are currently pregnant. So challenges to the fetus. Another class would be the checkpoint inhibitors, like the PD-1, PD-L1 inhibitors, like the pembrolizumab, nivolumab, and then CTLA-4 inhibitors like ipilimumab. These don't have a direct effect on ovarian reserve, but because there's that risk of endocrine disruption from the inflammation of many or different organs, there can be potentially hypothyroidism, hypopituitarism, hypophysitis that can downstream affect someone's ability to conceive or have a healthy pregnancy. And so they themselves may not change the patient's hormone levels, but then the effect on different organs can have an effect on patient's fertility future. So if we looked at the BCR-ABL tyrosine kinase inhibitors, so those are the ones for the ALL or CML, the effect is specific to c-KIT, which is a receptor within the ovaries and can lead to apoptosis and decreased cell proliferation. Also, there's an effect on this PDGFR, which is another receptor on follicles. It can also influence early follicle development and decrease total follicle count over time. And this is generally when the patients are on the actual therapy itself, the oral tyrosine kinase inhibitor itself. You can also see reduced responses in ovarian stimulation with changes in reduction in estradiol levels, which is important for the release of eggs. And yeah, when we stop the therapies, then the patient's risk of having these effects on fertility also decrease. So looking at the males, inhibiting c-KIT or PDGFR receptors can result in testicular development and result in decreased sperm production. There's also a decreased number of apoptosis on Leydig cells, and that could change the total testosterone that's available in the male's body. And specifically with the second generation tyrosine kinase inhibitors such as nilotinib and dasatinib, we may see that this have effects on the testes, but maybe very few effect on testosterone production. And on the other side, so what happens if patients are taking these tyrosine kinase inhibitors and they're pregnant itself? Well, there's information that crosses the placenta. So there could be effects on the placenta and the risk of angiogenesis on the fetus. But some of the information has shown that there hasn't been much transition or the passing of these tyrosine kinase inhibitors into the fetus, except for dasatinib. Dasatinib seems to have a higher risk of crossing the placenta barrier, and that could lead to physical or cognitive mutations in the child. So if we look at a study from Duoc et al., in CML patients, we had about 17 patients with molecular response, so they were currently in remission with their treatment. They were then studied to see if they were able to have full-term pregnancies. And 16 of those 17 patients turned out to have full-term pregnancies, where one had a spontaneous abortion. So we actually see that there could be healthy pregnancies when patients are in remission of their disease. And Romblada et al. Also looked at the effects of these BCR-ABL inhibitors on female and male fertility. They looked at patients who were receiving a first and second generation tyrosine kinase inhibitor and the effect of the sperm. And so we see pretty high rates of actually patients still having pregnancies, like full-term pregnancies that turn into children with live births. Also, this study looking at, it was a meta-analysis looking at several males who were taking tyrosine kinase inhibitors. They saw most of the patients were taking imatinib, and they also led to pretty high rates of live births and healthy births, where there are very few, few compared to the number of pregnancies there were, genetic abnormalities or malformations. But this actually gives us hope that patients who are taking these maintenance therapies can still conceive and still have healthy pregnancies. And then immunotherapies, fertility, we mentioned about the endocrine destruction, that these checkpoint inhibitors may not have a direct effect on ovaries and testes, but they can change how the endocrine organs function, and that can lead to having trouble with maintaining their hormones and conceiving. This was another cross-sectional study looking at immunotherapy and male fertility. And so in these patients, they were receiving pembrolizumab, nivolumab, and ipilimumab. They saw that there could be an effect on sperm count, but still their levels of hormones were not greatly affected. And we saw that of the 22 patients in this study, 2 of them had infertility, but the other 20 patients still were able to potentially have children. And so that's the last thing. The gonadotropin releasing hormone analogs, such as the leuprolide, goserelin, and digrelix, these are therapies that can affect and inhibit FSH, as well as decrease utero-ovarian perfusion. These have been discussed in the guidelines to potentially save fertility preservation for futures if we cannot undergo like a IVF cycle or sperm freezing. But they actually have not seemed to have a great effect to save fertility by putting patients on these gonadotropin releasing hormone analogs. So their main place in therapy for females is to suppress menses and reduce how much blood they are having during their menstrual cycle to help prevent thrombocytopenia, but they don't have a great effect on fertility. They don't have great responses to help patients with fertility. And for example, there are 3 agents. So the recommendations are for males who have undergone puberty that we can save their sperm for the future. For ovarian tissue cryopreservation, this is an option that's experimental, but it's the only option in patients for females who are pre-pubic. The benefit is that we can save that cortex, ovarian cortex, and not need for the whole IVF cycle, which requires about a month. And for women who are post-pubic, they can undergo egg and embryo preservation options. And then for the gonadotropin releasing hormones, that their place in therapy is mainly for the menstrual suppression, but they don't have the greatest recommendations for to protect the patients from infertility. And egg collection and embryo production, like embryo development, may not be an option for patients who have estrogen-sensitive breast cancer or gynecologic malignancies because of the risk of needing to give them gonadotropin therapies, and that could also lead to worse outcomes for their cancer. So lastly, for pregnancy risk after chemotherapy, women who are treated with anthracycline chemotherapy can have cardiac toxicity. Also, offspring of children who are cancer survivors may have germline cancers, mutations at risk. And then those who have had radiation therapies can have risk of premature births, low birth weight, congenital malformations and genetic mutations, as well as secondary malignancies. In summary, patients of childbearing age should be counseled about fertility preservation options before starting antineoplastic therapies or surgeries or radiation that can affect their fertility. Also, reproductive endocrinologists can be consulted to help provide fertility options based on the treatment goals and the timelines to treat their cancer. Ovarian tissue preservation, cryopreservation is an option for patients who are female, but mainly for those who are pre-pubic. The alkaline agents and platinum agents have the highest risk of infertility. And then small molecule inhibitors like checkpoint inhibitors have varying risks of infertility or fertility. So they have the option of having conversations to see if the patient's in remission before stopping therapies and pursuing a family. Also, patients who are planning to have a pregnancy or family should be closely monitored by their oncologist, reproductive endocrinologist, and their GYN, so a multidisciplinary approach. I'd also like to acknowledge Dr. Linda Sung, who had worked with me on these slides and has been a great resource to our team at NYU Long Island Cancer Care. And I know we're cutting close on time, but I'd like to thank you guys for your attention, and love to take any questions if you have time.
Thank you so much, Dr. Chin-Hon. I think we'll wrap up, and if anyone has any questions, we'll certainly reach out via email and get that to you. So thank you so much for your presentation today. I am going to now give the CE codes.